My name's Christie. I'm one of the neurosurgeons in town. Looking around, some of you know me, some of you. So I've been asked to talk about the surgical aspect of brain tumour treatment, I think. I've only got a few slides because I thought really it's up to whatever information you want, so please jump in and ask questions and whatever. I'll just sort of quickly go through it if I can. Fix it on, Sandy. Next one. Okay. So we like to think of the brain as a fairly ordered structure with nice, neat pathways going through it. Everything links up with everything else. It's all nice and structured, and we like to think sometimes that classification of brain tumours is similar. So we can have nice. 25 years ago when I gave this talk, this would be what I put up. You've got gliomas, grade 1 to 4. You've got meningiomas. You've got tumours that come from somewhere else. And then you've got a few other rare tumours, and it was all very nice and neat and ordered, and everything was very easy. Still, molecular biologists and other people came along and started mucking everything up for us. So now, this is actually a person who had a brain injury, and that's their impression of what the brain is like when they're recovering from their brain injury. I actually told that person that, in fact, if you do an electromicrograph of the brain, it looks surprisingly like that. So that's more or less where we are now with classification of brain tumours. They're all those things. So you've got oligodendrogliomas, appendicitis, polycytic, all different names that can confuse you, the bilio, various grades, and then now the molecular biologists have come in and we've got MGMTs and 1P19Qs and IDHs and promoters and suppressors of various genes, and it just gets very complex to try and sort it out. If we're confused, that everyone else is as well. And it's like quite a lot of things, the more research that's done, I think the more, at the moment, the more confusing it gets, which is good in a way. It means we're at least progressing somewhere. Where's the role of surgery in all of this? Are we letting the bad humours out, or are we letting bad things in? There is the concept that if you operate on something, that you may introduce something or change the nature of it. I think, as far as we know, that doesn't happen. We can make people worse, but I don't think we make them worse just by the fact that we let the air in there. I'm not sure that letting the daylight in makes a difference or not, but who knows. So, I guess you want me to concentrate mainly on gliomas today? Yeah, okay. I'll concentrate mainly on glioma surgery, or surgery for gliomas, although the other tumours are certainly very important, and we know people who've had meningiomas where they go badly, and some of those people are involved with the Hughes Foundation as well, fundraising and so forth. Broadly speaking, I think one can classify gliomas as low grade or high grade. And what are the differences? The low-grade tumours in generally tend to be somewhat more sort of diffuse, although they're all diffuse tumours, so they're less sort of circumscribed compared to other types of tumours. Tend to have a somewhat longer presentation history, maybe epilepsy going back some years and things like that. And certainly probably, I think in terms of what surgery tries to achieve, probably more controversial. In terms of whether you operate, how much do you operate, how much do you take out, do you do this, do you do that. So again, you'll get a lot of different opinions about that. High-grade gliomas, or grade 3, grade 4, I would tend to sort of lump them together. I must admit they tend to behave very similarly. And again, the surgery tends to be trying, can we get it out, can we biopsy, can we take a bit out? But there's probably less controversy in a way So, yeah, what is the surgeon trying to achieve for you? I guess one important is a tissue diagnosis, and I think that's probably, in a way, the most important part of surgery is getting tissue that the pathologist can look at and can do all those tests on, and then that can guide Mahesh and James in terms of what they're going to do with treatment. And although imaging is getting very good these days, you can probably 90% of the time you can look at a scan. We can look at a scan and say, yeah, we think it's this, and it'll be that. But there are times where we're wrong, and the pathology comes back as something unexpected or different. Occasionally someone might have something like an abscess, which can look very like a tumour, or it can be a different type of tumour to what we think it's going to be, maybe a lymphoma or something like that. That's going to change your treatment algorithm. So I think if possible, we'll certainly, most people try and get a tissue diagnosis. What else can we achieve with surgery? Well, I guess brain tumours present in different ways, as you all know. Sometimes they can present as simply a disturbance to the brain function, and that may manifest as epilepsy and fits. Sometimes they may interfere with some type of brain function, and that may cause some speech disturbance or some weakness or behavioural change, as you all know, depending on where the tumour is. And sometimes you may have a tumour that actually gets quite large and actually causes pressure in the brain. So the brain is, we think of it as a closed box. Am I still being heard down there? Keep it close to the mouth, right? Sorry. Hand up if you can't hear, sorry. So we think of the brain as a closed box, and there's only so much space in there, and if something starts to take up more space, your brain will tolerate that for quite a period of time, particularly if it's something getting bigger slowly. But then it'll reach a time where it literally runs out of space, and that's when people become quite headachy or vomity or start to lose consciousness and so forth. So someone with a big tumour, then part of surgery is to basically relieve those symptoms of pressure, and that's probably one of the more effective things that we can do. Sometimes the tumour, as I said, the tumours can interfere with function, and sometimes that may be partly what we call a pressure effect. In other words, the tumour's pushing on a bit of brain next to it and stopping that bit of brain from working, and if we can get enough of the tumour out, sometimes we may be able to make that person's function somewhat better, sometimes. Question mark, does surgery improve long-term outlook? And that's probably where you're going to find lots of different opinions, and that depends very much on the type of tumour. The location of the tumour is certainly very important to that. There are areas we can get to easily and areas we can't get to easily. There are publications and so forth out there saying, yes, if you can get a gross total removal of this tumour, then that person's going to do better than this person whom you can't. There is a little bit of evidence that points to that, but it's not as strong as we would like to think. Can reducing the bulk of the tumour make these guys' job easier? They would like to tell us that sometimes. So that if I can give Mahesh a smaller target to work on, then he thinks he can deliver more effective radiotherapy. Or if I can give James, if James has got a lesser tumour burden to try and hit with the drugs, then maybe that makes the drug treatment more effective. We like to think so. So the question as to which you often gets raised is, I get asked, I come back after surgery and I get asked, did you get it all? This is probably the most common question I get asked, did you get it all? And with rare exceptions, I think with gliomas, you can never say you've got it all. We can maybe get out all the visible tumour or all the tumour that one can see on the scan, But with gliomas, they are, as possibly been told already today, sorry if I'm duplicating anything, no. Okay, they are what's called, they're infiltrating tumours. They're not like meningiomas, tend to have a nice margin. Gliomas infiltrate through the brain. So even if it looks nice and neat, and even if you do an operation and you can see it and you take it all out and it's normal brain around, there's almost certainly little fingers of it going through there, going further away or in other areas close by. So there are a few exceptions to that, mainly in children. But in adult glioma, it's very rare to be able to say that one has sort of removed all the tumour and that's all you ever need to do. You're still going to be following and following and following and following. The decision we make regarding whether we just biopsy or whether we take some of it out or whether we try and take all that we can see out very much depends on the location of the tumour. So if the tumour location essentially is somewhere near the surface that we can get at, so here or here or up here, and we're not having to go through brain to get at it, then sure, we can try and get what we call as a gross clearance of that tumour. But if tumours are more deeply situated, involving more what we call Gallagher structures, in other words, bits of the brain that you need, then technically it's challenging to get to those parts of the brain, and if a surgeon tells you that something's technically challenging, that means the risks to you are higher. Yeah, it's very much a decision based, I guess, on the location of the tumour, what structures the tumour is involving, and in some cases you will, an individual surgeon's preference. There will be variations from doctor to doctor in what they think is operable, how aggressive to be. It really requires a discussion between patient and doctor as to what the aims of surgery are going to be, what the patient may feel is, the person may feel is a disability that they would accept, if there's a disability that they wouldn't accept, and it's very difficult. There's no easy answer to that. I'm certainly happy to take any questions about that aspect of it. So it's all those options are there, and it very much depends on what you think the nature of the tumour is and the situation of the tumour. So I just put one up. Sorry, it's a little bit blurry. Took that photo on my phone this morning. So it's a patient I had a discussion with this morning, and he gave permission for me to put his scan up. And that's really just to show you the difficulties, and I'm sure most of you have probably seen scans by now. So what we're seeing is, I'm going to point at it, is you can see all those little bright spots up there straight above me now. So those are all little bits of the same tumour in different parts of the brain. That's right in the centre of the brain at the front. So you've got what's called the corpus callosum, which is the sort of connection across both sides of the brain there. That's there. It's going down very deep towards fairly major arteries at the bottom, and you can see it's a long way in from anywhere. So, just for someone to say, oh, I can remove, yes, I can remove all of that tumour, but the likelihood of me leaving that person with fairly significant disabilities is pretty high to do that. So, it's a trade-off. You take out what you can. And had a long discussion with that person and his family before surgery, and he said, yes, I'd rather you be conservative. I don't really want to sort of lose much function, so that I took that into account with the surgery. So that just illustrates really what the difficulties can be with surgery. So why, you say, oh, so you might say, oh, so-and-so said he got all his, all his tumour is out, and why isn't mine all been taken out? And they're going to be the reasons for it. Let's talk about reoperation. And lastly, Sandy asked me to talk about what the role of second surgery is, or reoperation. And again, that's a very difficult one. There are no clear guidelines for it. There's a great lack of sort of evidence for it. But I guess there are some people who, for instance, you may have got a reasonably good clearance on their first operation, and they've gone for a reasonable, all the treatment from these guys, gone for a reasonable period of time, functioning well, and then the tumour starts to come back again or regrow again, and we're asked, oh, can you operate again? It's very much an individual decision. I think from a surgeon's point of view, if what we can see on the scan is fairly favourably situated, that we can get at it. If it's causing some symptoms, maybe another reason we think we can relieve those symptoms, then yeah, there may be a role for further, as it were, debulking of the tumour. And again, if we do that, then we've got tissue again that can be looked at, and again, it can give James and Mahesh sort of some guidance, and they may be able to come up with some second line treatment in those situations. With lower grade tumours, again, if they remain lower grade, sometimes, as you know, low grade tumours can transform into higher grade tumours, and that may be another reason to reoperate, to get tissue to see what the tumour is doing there. It's very much an individual decision on each individual case, and I don't think there are any real guidelines that one can sort of give you about that. So that's about as much as I've prepared in terms of me talking.